on the road, in the gym, at a coffee house. No matter where you listen, this is Prevention Perk. I'm Steve Miller with midamericapttc. It's time to perk up our prevention efforts. My guest today is Dr. Fred Rottnek, professor and director of community medicine at St. Louis University School of Medicine and the program director of the St. Louis University Addiction Medicine Fellowship. I met up with Dr. Rottnek at the Kansas Prevention Conference where he spoke about the intersection of substance use and trauma. What intrigued me about his presentation was the simplicity with which he speaks and his depiction of the lizard brain, wizard brain. I hope you enjoy this conversation as much as I'm looking forward to having it. Hello, Fred, and welcome to the Prevention Perk.
Well, hello, and thank you for having me with you today.
I really enjoyed your presentation. We had a short conversation afterwards, and I'm looking forward to kind of unpacking a little bit about what you talked about on the stage. But before we get into that, tell me a little bit about how you got into this line of work. Like, what was your path into prevention work?
Okay. Long story. We'll make it brief. I'll give you the Fred Rottnek liner notes. First in my family go to college, second generation immigrant family. So my parents didn't know what to do with me, but they knew I was going to college. Ended up majoring in chemistry and got a full ride to Harvard, believe it or not, for graduate school. Way back when, we didn't know what major depression was. So after I got to Boston and Cambridge, had my first major depressive episode, came back to St. Louis, taught high school for a few years during my medieval years. Then I was going to be a Jesuit priest, went to the novitiate for 8 days, came back, finally saw a psychiatrist, second major depressive episode. Prozac was new then, so that shows you how old I am. And I took kind of an inventory of my life and thought, what's important to me? In a way that I hadn't done before, because I was kind of on a conveyor belt of success and just kind of kept doing what showed up. So I thought about, I wanted to incorporate my values in my work. I love teaching, and the Rottnek idea of a hobby is a second job. So I ended up going into medicine. When I got there, the elective I had my first year was doing homeless healthcare. Something really clicked, having grown up in a family business and working class folks, working with folks who are housing insecure or flat out homeless. That brought me into a lot of electives doing work there, went into family medicine. And after working and volunteering in shelters for 6 years, I had the opportunity from my employer to start doing correctional healthcare. And I knew at that point who would be most of my folks seeing in a correctional setting: folks with substance use issues, folks with serious mental illness. After doing that for 15 years or so, and teaching the whole time, I got into it with the county executive when he wanted to privatize healthcare, took it to the press, kind of got me out of the jail for that time. But that was the time that addiction medicine became its own specialty in 2016. So ever since that time, I have been building our addiction medicine fellowship with our colleagues here at St. Louis University. We're currently in our 5th year of training physicians from any medical specialty in this work. And what got me into the prevention side of things, quite honestly, one is working with teenagers in juvenile detention, which I've done most of my career, and realizing that they hear things a little differently, and sometimes finding their motivations for use or risky activities is really important, and connecting with them and helping them make good choices. But the other piece is having really taken a look at what we're trying to do right now in the age of fentanyl, is realizing we're not going to reverse our way out of the opioid overdose epidemic. We're not going to treat our way out of it. We've got to move way upstream and figure out how can we have the kind of education and prevention programs so that people don't think that using a substance even once that is so risky is a good choice. So how do we really look at prevention in terms of not only individual choices, but community health and well-being?
You're listening to Prevention Perk. The funder of this project, along with all the other products of the midamericapttc, is the Substance Abuse and Mental Health Services Administration. Although funded by SAMHSA, the content of this recording does not necessarily reflect the views of SAMHSA. The human brain is the most complex organ in the body. Drugs can alter important brain areas that are necessary for life-sustaining functions and can drive the compulsive drug use that marks addiction. The National Institute on Drug Abuse, NIDA, has a great resource available titled Drugs, Brains, and Behavior, The Science of Addiction. There is a link in the show notes to this publication. In your presentation, you talked about that intersection between trauma and substance use. Probably a lot of people in our audience are familiar with those two words, trauma and ACEs. Could you kind of unpack both of those just briefly, like the 1,000-foot level? What is trauma and what are ACEs, and why is there an intersection with substance use?
Absolutely. When we talk about ACEs goes back into the 80s in terms of it being a study. And what ACEs stands for is Adverse Childhood Experiences. Dr. Vincent Felitti was doing his side hustle working at a program for mostly women with eating disorders. And he found out that when the women were in the residential program, they did really well. When they went back home, however, they often engaged in the risky eating behaviors again, what we might refer to as relapse. But they re-engaged in those behaviors. When he did a chart review back in the 80s, we were still on paper charts. I always point that out to young people today, before we had computers for everything. He did a chart review and he noticed that for the 100 or so charts he looked at, almost all of the women had been sexually abused as children. And it got him thinking, what does this kind of trauma have to do with eating disorders? Well, that was kind of the spark that has grown in the subsequent decades to look at how does physical, sexual, emotional abuse, or even trauma from natural disasters, trauma from wars in other countries, trauma of the refugee experience, how do traumatic events in somebody's life show up later in their health status? And that's what the ACEs study has really been looking at for decades. It's been a combination of Kaiser Permanente, where Dr. Felitti was initially in this practice, and the CDC, and finding out that there are strong correlations to our health as adults to the trauma that we experience growing up. And this trauma is additive. So people can have an ACEs score, which points to originally 10 different domains of types of trauma. Now, the interesting thing on how that intersects with substance use and people who have an active substance use or maybe very early in recovery is both trauma and substance use affects our brain, and it affects brain development. We know that the two parts of the brain that I'm most concerned about, I should say, as a simple family doctor and addiction medicine doc, are the brainstem and the prefrontal cortex. And I'm pointing to parts of my head like you can see them right now. But the brainstem is top of our neck, the top of where our spinal column tops out. Okay. And that is the first part of the brain to really develop for any terrestrial animal, including human beings. The brain stem is a part of the brain that controls our survival instincts, our fight, flight, freeze, our eating, sleeping, drinking water, our desire to procreate. Think of the brain stem as a part of the brain that controls our survival mechanisms. We know that when young people are growing up and they're exposed to a lot of trauma, that part of the brain hypertrophies. It grows much larger than it would in somebody who hasn't experienced trauma. And why does that part of the brain grow larger? It's because that's the part of the brain concerned with survival. And when people have a lot of trauma in their life, the natural response of the brain is to really be protective and help people stay alive. Now, when we talk about the prefrontal cortex, the part of the brain, our cerebral cortex right over our eyeballs, that's the last part of our brain to develop. It's that of what we call highest functioning, or more like I like to say executive functioning, the part of our brain that is active when we go to work every day so we can get a paycheck on Friday. The part of our brain that's running the show when we enroll in a university or college program to get an advanced degree. It's the part of the brain that has to do with thriving. Now, these two parts of the brain, what I call the brainstem, or as the scientists in the 1800s who started doing consistent dissections of animals, they said that even the lowly lizard had a brainstem. So this part of the brain I often refer to as the lizard brain. Remember, survival, fight, flight, freeze, etc. This part of the brain, together with the prefrontal cortex, remember, this is the executive functioning part of the brain, the prefrontal cortex, or the wizard brain, the part that can tamp down the brainstem. These two parts of the brain work together when people are healthy, when people are functioning well, when the brain is interacting the way it was intended. These two parts of the brain get disconnected in trauma and also get disconnected when people have an active substance use disorder, because these are also the parts of the brain that moderate the pleasure responses in our body, the reward circuitry. When these two parts of the brain function well, I will joke oftentimes that I'll drive by one of my favorite restaurants on my way to school in the morning and think, oh, they have the best Bloody Marys here. So big in a water glass with candied bacon and everything in the deli on a toothpick, right? That's my lizard brain talking. That's my part of going, I'm kind of having an urging or craving for that Bloody Mary right now. Now, my wizard brain tamps that down and says, Fred, you've got a full day of teaching. You've got Zooms. You've got a podcast to record today. Maybe not the best day for you to get a Bloody Mary at 7 a.m. That's how it's supposed to work when they tamp things down. Now, in active use, especially with opioids and alcohol, these two parts of the brain don't talk to each other. And when they don't talk to each other, we can guess what part of the brain always wins, and that's the lizard brain. That's why when we think about times in our lives or times in the lives of people we care about or patients or clients, when people are in active use and the brainstem's running the show, survival mechanisms are running the show, right? And we're thinking about what's going to happen in 5 minutes, not in 5 years. Same thing happens when people are exposed to a lot of trauma in their life. They function out of their brainstem, and that might show up as fear. That might show up as a startle reflex. That might show up as quote unquote bad behaviors, where people are more concerned about what's going to happen in 5 minutes rather than 5 years. So now the two come together when we talk about the brain circuitry, but I always think that's really an interesting way to think about not only substance use or when people are exposed to trauma, because if we back up a little bit and learn about how the brain functions, it helps us understand our behaviors as well as behaviors of people we're trying to help.
You know, in your presentation, you talked about why science is important. And as you're unpacking this, I mean, you're kind of talking about the science of brain development. One of the things that you also mentioned is in your history is that you were a high school teacher. And I'm just curious, why is science important? When you present it in this way, are teens, when you're in that classroom and you're interacting with adolescents, are they receptive to this kind of information? Because I know they kind of zero out on the scare tactics that have, been pervasive for decades. Is that a part of why science is so important, not only for us adults to understand, but is it important that an adolescent gets that about themselves?
Absolutely. I think one of the interesting things about a little bit of brain chemistry, I always say 5 minutes of brain chemistry will drive out a year of moral failing. If we can talk about that, our bodies are actually doing what they're supposed to do. It's a whole lot better than just saying, stop doing that. For example, teenagers know they're impulsive. teenagers know they do stuff that they're not always thinking things through. And when I talk to like now, you used to teach high school before med school. Now I take care of my kids at juvenile detention. And I will tell them sometimes, when you have those urges and cravings to really do something that you really know better that you shouldn't do. And they'll go, yeah. And I'll say, I'll tell you why. It's because when we tell you not to do something like that, this part of your brain isn't fully developed yet. You're 16 years old. This part of your brain isn't fully developed until you're 25. That's why sometimes we need to have more rules for you when you're growing up until you get older, so that there's certain things that we recommend you do and don't recommend you do, because you still have a lot of growing to do physically and also in terms of your nervous system. So sometimes something that might look like a good idea for you right now may not look like a good idea 10 years from now. So that's why we sometimes ask you to slow down a little bit and think things through. And I find out when I phrase things that way, it's much better than saying, don't do that because I said so. It's rather, I care about you, and this is why we ask you sometimes to slow down a little bit and to think things through.
I remember I did a presentation, and I believe it was probably a middle school setting, and one of the things that was in the Q&A that was brought out was they said, we like it when you shock us. And I thought about that for the longest time. And I don't think it's like the scare tactic kind of thing. I think it's kind of like that shock is kind of a part of that developmental experience. It's like that intensity, that, oh, wow, this is cool kind of thing. But it also needs to have like an educational component to it for it to really have some kind of a lasting impact. So that's why I was curious about the brain development aspect, because part of that's kind of like, wow, that's kind of a interesting thing to think about, and then bring it to life by using real life examples for themselves. I could see would be kind of like, well, that's kind of shocking, it'll stick, as opposed to, yeah, I've heard it all before.
Well, yeah, and we can think back too, because we have some wisdom highlights in our hair here today, Steve, when we're talking to each other, right?
But yourself.
I know. We think back to we like being surprised, right? When we're young people, we have a sense of wonder about us. And I think that's where the shock comes in. I think young people, by and large, like to feel that light bulb going off, right? Going on, I should say going on, not going off. And I think as we get older, sometimes we tend to find some false security around feeling like we know the answer. Talk to people, including the talk we were talking about in Wichita this fall. I get such a kick out of looking around the room when we talk about certain topics, and you can see the light bulbs go off in people who are in their 40s and 50s and 60s and go, I never thought about it that way. Or I never really understood how naloxone works. And those for me are so rewarding, because I think sometimes we forget that we really do like being surprised by learning something new. And we don't always pursue that as much as we might have when we were younger.
Well, you talk about the science of the brain. I also found something intriguing in your conversation when we first met up. The science of stigma, and stigma gets talked about a lot, but let's unpack that a little bit. What do you mean by the science of stigma, and how does that play into this conversation?
The science of stigma is so important because we all grow up with certain messages that get hardwired into us, right? I like to call them kitchen table conversations. I don't know if that still is true. I don't know how many young people still eat at a kitchen table, but I know we always did growing up. Dinner was always at the same time, and grandma might be over, or aunt and uncle might be over. And there's certain things that just kind of get hardwired in. And those things that get hardwired in really affect how we look at the world. A good example I always give is that Grandma Hilda did not like fat people. And I say it that way because that was the language she always used. So I grew up thinking that people who were overweight had something wrong with them. They had motivation issues. They just couldn't control themselves. But it's something I didn't realize until I was really taking care of people as a physician who were what we all considered to be overweight. And it made me think, how is this affecting my practice? And how is it affecting how I'm seeing individuals? Well, when we broaden that out and we look at stigma and bias that as a community or even as a country we might have, we see that we end up creating systems based on the stigma that we have regarding other people. Great example is people like we're talking about today, people with substance use disorders and folks who might have co-occurring mental health issues. In the past, and too much still in the present, we would say that somebody's got a problem with alcohol or opioids or nicotine because they're not trying hard enough. So if they just tried harder, they'd be okay. We don't say that about people with blood pressure problems. We don't say that about people who have diabetes. We don't say they just need to try harder. We say, hey, you have a medical condition, and hey, we've developed medications that can help you. We know what works in terms of diet, in terms of exercise. So, excuse me, when we have stigma against a group of people or people with certain characteristics, we end up creating systems that reinforce that stigma. And what that does is it pushes people further away from the mainstream. And it also reinforces that stigma within individuals. There must be something wrong with me because I can't stop blank, rather than thinking of substance use issues and untreated mental illness as biological entities that we could intervene with medications, with behavioral change, with exercise. So the science of stigma is so important because we need to look at what we're doing, how we've created systems that otherize or disenfranchise others. And that if we have interventions, let's keep track of what interventions work, how they work, and then let's turn those into best practices and standards of care.
You know, in the landscape today around prevention and in a broader spectrum than just prevention, there's a lot of discussion about harm reduction. And I'm sure that this conversation about stigma dovetails right into that. And how do you see that playing out? Because, you know, harm reduction is relatively new in the dialogue around substance use. And it could be in other areas of the medical practice that I'm not aware of. How does stigma kind of attach itself to that conversation, and are there ways to kind of start debunking some of the myths that surround that?
Absolutely. A part of me wants to get rid of the term harm reduction and just talk about making good choices. And I'll give you an example. We don't think of a seatbelt as harm reduction, but depending on who we ride in cars with, we may, but many of us don't. But seatbelts are 100% harm reduction. When we get in a car, we're engaging in an otherwise risky behavior, right? There is nothing natural about getting in a couple 1,000-pound device and hurtling down the highway at 60 miles an hour, okay? We know that seatbelts help save lives because if something bad happens, we tend to be a lot better off if we've got a seatbelt on in a car. Okay. Now let's zip forward to drug use and substance use. We know that when people use drugs, there's reasons people use drugs. Sometimes it's because they make us feel good. Sometimes we know it makes us feel less bad, but there's a benefit to them. Not everybody who uses a substance one time will develop an addiction or even have risky use associated with it, but some people will. So where we look at harm reduction and how that fits in prevention, I like to call it that the more you know. Remember the rainbow we used to see on the commercials with the unicorn and the star and everything? Mm-hmm. Science can really inform us if we're at risk for bad things happening when it comes to food choices, when it comes to exercise, when it comes to crossing the street, using a seatbelt, trying marijuana, drinking alcohol. We know we have innate factors, genetic factors. We know we have environmental factors. So the more that we understand how our body works and how our genetics can put us at risk and how our associations with other people can put us at risk, we can make better choices. So I always think that harm reduction is a response to the human condition. For teenagers, harm reduction is often something about how do we tamp down impulsivity and how do we tamp down risky choices. For adults, harm reduction might be if you're actively using a substance, but you're not yet ready for treatment, how do we keep you alive until you may someday be ready for treatment? It's just another tool in the tool belt to keep people alive and hopefully give them opportunities to engage in the healthiest behaviors they're ready for.
You're listening to Prevention Perk. A podcast is like a breakout session from your daily routine. It's a unique way to perk up your prevention efforts. We'd like to hear from you. Please send your comment, topic, or guest suggestion to midamericapttc@gmail.com. You probably recognize this, but in the line of work I do, and certainly in the line of work you're doing, we talk about this kind of stuff all the time. But you used the statement earlier. I think you said kitchen table conversations. It's not something that's talked about amongst mom and the kids, or two grown adults having a conversation about ACEs and trauma and what is the science behind this or that, and let alone get into harm reduction. But one of the things that I think I heard you say something about opening conversations to normalize discussions around substance use, mental health, and trauma. Basically, you're talking about like healthy conversations. And I'm always curious, how do we start facilitating the conversation beyond this that we're having, or you at the podium and we're in the audience as professionals listening? How do we start having those conversations in a healthy manner as a part of the day-to-day? Did you see the sports? How was your holiday? Are you going to see the family? Oh, and by the way, did you hear the latest research? I mean, that's a far-fetched, I think, in some ways, but in other ways, it's kind of intriguing. It's like, how do we start facilitating normal discussion about all of this that we've just unpacked in the last 25, 30 minutes?
Yeah.
Yeah. How do you talk a little bit about like the healthier conversation aspect?
Sure. One of the tools that I love using that I was involved with, and actually you can go on their website, Addiction is Real. It's a St. Louis-based program. They have a phenomenal 50-minute documentary called Don't Wait. And it is all about having conversations with young people, starting in kindergarten, going up through high school. Not all about substances, but about healthy behavior and healthy choices. And what are your friends doing? And what kind of seems normal for them? And I highly recommend it. We have done a lot of panel discussions with this, with schools, with church groups, with youth groups, etc. But I bring it up because some of the things we talk about in there is talking about family members who have struggles with substance use or mental health. Without demonizing somebody in your family, sometimes you might say something at the kitchen table about, yeah, grandpa always had a really hard time with grandpa because he drank a lot. And, if grandpa's gone, if he's passed on, that might be an opportunity to say, do you ever wonder why somebody might drink a lot and have a really hard time with their life? Well, it's because grandpa was depressed a lot. And grandpa knew that if he drank, he could kind of turn off that part of his brain that hurt. But the sad thing is, when grandpa drank, he didn't behave really well with grandma and with, my brothers and sisters and me. So it's that idea of getting behind the behavior a little bit and those next steps. Another similarity, and I know this has become kind of a morbid habit of mine, whenever a celebrity overdoses or dies, I look up to see what happened. Or if somebody dies, it's like with I'm thinking his name now, Matthew Perry, when he recently died from Friends. Matthew Perry was very open around having a substance use disorder, but it took the toxicology reports for people to say what his cause of death was from. And young people often have celebrities they follow. So it's always a good opportunity to say, hey, I saw that somebody went into rehab. Do you ever wonder why somebody might be using drugs when they seem to have everything in the world? So there's kind of some ways in to talk about people that young people think are important or people that young people look up to. And like recently with Rosalind Carter dying and talking about all her advocacy work for folks with mental illness, that's kind of a cool way to, rather than talking about a study or something in the abstract, talking about an individual that somebody might admire who takes a strong stand one way or the other.
I think what it comes down to, there's not a magic formula for this. It's being intentional about it, but it goes back to the conversation we had earlier. It's like, it has to be not shocking, but there has to be some kind of an intrigue, or there has to be a reason why. It's fun to talk about whether your sports team won or lost, but how do you make it interesting or intriguing or engaging around this? Because we're really talking about ourselves or people that are close to us that we're concerned about. The trick is how do you have that conversation, or how do you begin that conversation? And sometimes people just don't know where to begin, let alone how they're going to unpack it once they start beginning. So healthy conversations is not top of mind, I think, is what I'm getting at.
Well, the other thing that comes in nicely with a healthy conversation is, one, knowing that you don't always have the answers, and that's absolutely okay. But the other thing that can come from them is, as you just mentioned, Steve, this idea of really fomenting or promoting curiosity, right? Like when somebody who may be at the top of their game externally, a lot of fame, a lot of success, but something bad happens to them, really saying to a young person, well, why do you think they did that? What do you think could have happened here? Why do you think somebody might have a DUI when they just won an Academy Award? And really kind of thinking about those curiosity pieces, because the nice thing about talking about an individual is a way to start humanizing these issues, right? And if we can put a human face on a struggle, it takes away the abstraction, because if we care about somebody, we tend to be a little more generous and give them a little more grace and a little more space to talk about what might be going on in their lives.
I know you're also kind of an expert, and you talk passionately about cannabis use. You and I both live in the state of Missouri, and in the past year, it's become legal for adult use in our state. I don't want to unpack all of that conversation. I was thinking that maybe at some point we might have you come back and we'll talk at a much broader depth about cannabis use. But what is that most important thing? Like, I was just going to leave one little tidbit for the audience to think about in regard to cannabis that we should consider, especially if we're going to talk about adolescent experience, not even as an adult. What's the thing that we need to be top of mind aware about this whole new world that cannabis presents?
When you use cannabis, you're never really absolutely sure what you're getting. Even things in the dispensary are not FDA controlled, right? It's not legal at a federal level. And a lot of the stuff that's being sold today, especially in the dispensaries, are extremely strong products in terms of the psychoactive substances present in that. What I often tell teenagers and young adults is we're seeing more and more correlation between regular cannabis use and what we call hyperemesis syndrome, where people just develop uncontrolled vomiting, end up in the emergency room. Or we'll see young people develop some psychotic breaks from cannabis use. So it's one of those situations where be very careful how often you use it, if you use it. Be careful about the potency of stuff that's available. Don't just take something from a friend because you really don't know what you're getting. That being said, if you have questions, ask. you might want to ask your parents, or you might want to ask a trusted adult. But there's a lot of information that's floating around out there that's just not true. And to say that cannabis is safe because it's natural is just like saying opium is safe because it's natural. It's do some homework from resources like the CDC. Learn about this stuff. Learn about things and the information that's available, and make good choices.
You're listening to Prevention Perk. It is reported that only 25% of parents speak to their children about the dangers of drugs. How can we help educate parents on the dangers of drugs and alcohol and provide them with the tools needed to guide and engage children through this very rough and sensitive terrain? Addiction is Real can help answer this question. To learn more, visit addictionisreal.org. It's a big topic, and I would, if you'd like to, I'd extend the invitation. We'll have you come back and we'll really kind of dive into cannabis. And I think there's probably differences in the ways that cannabis is administered, edibles, vaping, all of that. And we could talk more about that. But along the lines of the trauma and the science, is there anything that we haven't talked about that you want to make sure the audience knows, or a resource that maybe you think is a really trusted resource that they could turn to maybe answer some of the questions that may have come up for them as we've had this discussion?
Absolutely. A great resource is a monograph from NIDA, NIDA, which is this National Institute on Drug Abuse. Awful name, but a great organization. They have a monograph called Drugs, Brain, and Behavior. And it's a very digestible, very easy to read, well illustrated guide on the impact of brain, drugs, and behavior, just as we mentioned, with resources with trauma there as well. Another great teaching item that I would like to say that in terms of not only driving out moral failing by understanding some of the chemistry with this, but the other thing is to just give people some space when people are behaving in ways that you don't understand. I teach clinical interviewing to our medical students here at St. Louis U. And I always tell them, when patients answer questions or behave in a way that doesn't make sense to you, chances are you're not asking the right question. The reason I like people to think a little bit about the lizard brain and the wizard brain and how the two connect or disconnect is when people have untreated and undertreated mental illness and substance use, it may seem that their brain isn't working right, and chances are it isn't. So give them some space to heal. Have patience with them and have patience with yourself, patience with a C, and allow the brain to do some healing. And don't expect everything to change with one intervention, because we don't develop problems immediately and we don't find solutions immediately. It takes us some time. And that's where we need to kind of mimic the people in our life who are good parents and good relationship folks who know how to give people the space to get better.
My guest on this episode has been Dr. Fred Rottnek. You'll be able to find links to connect with him in our show notes. Thanks, Fred, for being here with us today.
My pleasure, and I would love to come back and talk more.
And thank you for listening to Prevention Perk, a podcast from Mid-America PTTC. To learn more about our innovations, visit pttcnetwork.org and look under your PTTC for the Mid-America link. Remember, prevention is better together, and together we are stronger.